Good evening, everyone. I'm Dr. Galen Henderson, Brown class of 1993 from the Warren Alfred Medical School and the former BMAA president and former BAA president. I'm here to announce the Charles O. Cooke Distinguished Visiting Alumni Lecture, Navigating Bias in Healthcare and Medical Education by Dr. Augustus White. I want to thank you all for coming tonight. This is so important and really pertinent in this particular time. Now, I would like to introduce our Dean, Jack Elias. Jack Elias is the Senior VP for Health Affairs and Dean of Medicine and Biological Science and the Frank Day Professor of Biology at the Warren Alfred Medical School. In his over 30-year history of research, he's an immunologist and has trained more than several hundreds of researchers, published more than 230 peer-reviewed research papers, and cared for numerous patients with a wide variety of lung ailments and immune and allergic disorders. Dr. Elias.
Hello, and welcome to the 2021 Charles O. Cooke Distinguished Visiting Alumni Lecture. The Charles O. Cooke Distinguished Visiting Alumni Lectureship was endowed at the bequest of Mrs. Ruth Cooke Peterson to establish a lectureship in, quote, any branch of medicine which can hold the promise of significant and lasting benefit to medical education at Brown or to the community or to the delivery of healthcare services. As conversations about the disparities that exist in medicine, research, and the delivery of care continue to happen throughout our nation and around the world, we wanted to focus this year's lectures on health disparity. As academic healthcare leaders, we believe we have a responsibility to build community awareness and create ample space for current and future healthcare professionals to discuss how disparities in race, ethnicity, and culture and economic inequities will impact their chosen fields. To that end, I cannot think of a more fitting trailblazer to be delivering this year's Cooke Lectureship than Dr. White. Augustus A. White III was born in Memphis, Tennessee, the son of a doctor and a librarian. After attending segregated schools in Memphis, Dr. White graduated from the private Mount Hermon School in Northfield, Massachusetts in 1953. Dr. White completed his pre-medical studies at Brown University in 1957, and in 1961 was the first African-American graduate of the Stanford University School of Medicine. He performed his internship at the University Hospital in Ann Arbor and his residency in orthopedic surgery at both San Francisco and in New Haven, where he was the first African-American surgical resident at Yale New Haven Hospital. He then served in Vietnam from 1966 to 1968, rising to the level of captain in the Medical Corps and being awarded the Bronze Star. In 1969, he received a PhD degree in orthopedic biomechanics at the Karolinska Institute in Sweden. Also in 1969, upon returning to the United States, Dr. White rejoined Yale Medical School as an assistant professor and remained at the university for the next decade, becoming a full professor and then director of its biomedical research department for orthopedics. In 1978, White was recruited to the Beth Israel Hospital in Boston, where he served as orthopedic surgeon-in-chief for 13 years. He also founded the academic orthopedic program at the Beth Israel Deaconess Medical Center. White currently holds the titles of Professor of Orthopedic Surgery, the Ellen and Melvin Gordon Distinguished Professor of Medical Education, and Orthopedic Surgeon-in-Chief Emeritus of the Beth Israel Deaconess Medical Center. A noted author in his medical specialty, White co-wrote Clinical Biomechanics of the Spine and Biomechanics of the Musculoskeletal System. White also wrote Your Aching Back, A Doctor's Guide to Relief, Back Care, Advances in Spinal Fusion, Molecular Science, Biomechanics, and Clinical Management and Clinical Biometrics of the Spine, which is a standard reference book for orthopedists. Since retiring from surgery in 2001, White has researched and written about issues of diversity and cultural sensitivity in medicine. In 2006, White was awarded the American Academy of Orthopedic Surgeons Diversity Award for his life's work and his contributions to his field. In this afternoon's talk and fireside chat session, Dr. White will explore the reality of bias in medicine, its effects on patients, and how better training can help improve disparities in delivery of care. I am honored and excited to introduce you today to the 2021 Charles O. Cooke Distinguished Visiting Alumni Lecturer, Dr. Augustus A. White III.
Good evening, my fellow humans. Dr. Elias, thank you, sir, for that very full and engaging introduction. I appreciate it very much. And I would like to extend my appreciation to Mrs. Ruth Cooke Patterson for her generosity in establishing this lectureship. Thank you. I greatly appreciate the privilege and the opportunity to share some thoughts and ideas to hopefully move the agenda into a more humanitarian mode as we go forward. Of all the forms of inequality, injustice in health is the most shocking and inhumane. This is a quotation that is frequently referred to, and I think it's important. And I think the topic and our purpose for being here together involves a huge and extremely complex and extremely complicated set of realities and information. And there's so many different perspectives that can help us to understand and cope with the realities of the problem. And this quote makes you ask yourself, when are we most vulnerable? It's when we're ill. When are we frightened? When might we have to go to a stranger for help? When might we have to go somewhere where we don't speak the language for help? And when you then have and must encounter injustice in this situation, when you are most vulnerable, this is what helps us to realize that this is very inhumane. And with Dr. King's inspiration and leadership, we all do what we can in our spheres of influence to improve this unfortunate reality. And this will be one of the themes of our talking together this evening. Next, please. Okay, now this involves most of the people who experience healthcare disparities. And let's just go through it. African Americans, the Appalachian poor, Asian Americans, elderly individuals, lesbians, gays, bisexuals, transgender people, LGBTQ people, immigrants, Latinx people, Native Americans, overweight people, people with disabilities, some religious groups, prisoners, and women, our mothers, our grandmothers, our wives, our fellow humans, all experience healthcare disparities. And unfortunately, intrinsically coupled with the healthcare disparities are frequently social inequities, which resonate with the challenges that we must face. Next, please. This is a portrait by Rembrandt, and it represents Moses when he was climbing up Mount Sinai. And Moses was moving along, and he's going to give you, I'll give you an example of something that maybe you didn't realize, but he is depicted, and there is one of the slats, one of the charts that contained the commandments. And as he was walking up the side of the mountain, he slipped, and this is often thought to contain the 10 commandments. And he slipped and fell, and a piece of the chart broke off and slid down the mountainside. And there was a commandment on there, and I'll bet not everyone listening here today knows what that commandment was. Well, I'm going to tell you, you learned here at Brown in this lecture about the 11th commandment. And that broke off when Moses fell and slid down the mountainside. And the 11th commandment, let me share with you now, is thou shalt not commit isms. So there we have a thought from history, a little bit revised by your speaker, but there it is to think about. Next, please. So what are we talking about? Commandments, not committing isms. Well, here are a few of the more visible ones that we don't want to commit. Ageism and sexism, racism, classism, ableism, xenophobia, ethnocentrism, heterosexism, transphobia. And sadly, I can remember, and I bet many of us will, if we think back at the beginning of the last presidency, within the period of the first months of the incumbency of that presidential leadership, we had seen highly visible examples of these isms manifested in our news in different iterations night after night. But this just gives us some idea of the challenge and the opportunity. Next, please. Here's another bit of artwork. I'm an art connoisseur, as you can see. But here is a cartoon that I thought was rather compelling. The cartoon is that of a lady sitting on the table, maybe a little bit overweight, and apparently African-American. And she wants to get right down to the point. And she said, "Give it to me straight, doc. I can take it. Tell me what's wrong with me. I'm here. I want to know what's wrong." And the doctor, well, I guess he tried to be equally as frank, and he said, as you see here, "You're not a white male." But that does say a lot. That says an awful lot. Next, please. And here's another depiction that I feel is very helpful in communicating and in thinking about racial realities. It comes from the Center for Comparative Studies of Race and Ethnicity at Stanford, which has done a lot of work for many years around issues of race. And the picture shows an iceberg, and they call the Racial Iceberg, and that resides in the Sea of History. And if we look at what's in the Sea of History, it's rather interesting because therein, around this racial iceberg is it's difficult, sad realities of slavery, of colonialism, of the Civil War, of immigration, Japanese internment, lynchings, and several other items that are intrinsically involved with racism. And much of the visibility of it is beneath the surface, but still has a tremendous presence and tremendously operative. And so everyone, here's some of the mythology also floats out in the clouds. Everyone is not a racist, and we're beyond race, and all of these background realities that impact on the realities that we are faced as caregivers and as people who want to do the right thing and make changes. Next, please. And here's a definition that comes right out of Stanford. Two of the professors there have put this together, and I think it's marvelous, and I think it's worth reading. Race is a doing, a dynamic set of historically derived and institutionalize ideas and practices that sorts people into ethnic groups according to perceived physical and behavioral human characteristics that are often imagined to be negative, innate, and shared. It associates differential value, power, and privilege with these characteristics, establishes a hierarchy among the different groups, and confers opportunity accordingly. And one of the things that we experience and we know about that are so prominent are the so-called social representations of health disparities, the socially based health disparities, zip code based health disparities. Your life expectancy is largely impacted and dictated by your zip code. And there are numerous examples. It's like that iceberg that's ever present and operative. Next. So we can think that the principle of social justice is cited as one of the three fundamentals which all medical professionals can and should aspire to. And this is what we encourage ourselves and our students to do the best we can to do. There's a classic paper published, the full text doesn't quite show up on the screen, but it's published in Lancet, and it looks at the physician professional responsibilities. And it includes, this was done in the early 2020 year, and it's reviewing medical professionalism. And they say that our responsibility as medical professionals is to guarantee patient welfare, assert patient welfare, advocate and work for patient welfare. And the other is patient autonomy. And the one that I want to emphasize, though, and the third one is to affect and work to correct social issues in the society that impact patients' health. And there we are again, the social determinants of health, major reality and challenge and opportunity to make a difference. Next, please. So here we're dealing with a formidable national problem, and it's an unconscionable reality, actually. And it's so unjust, it's so immoral, it's so unfair, and it's so real because we are all so vulnerable when we are sick and we need health care. And it's a moral, ethical issue, as well as an extremely complicated sociological, economic issue. We can want to do the right thing, but that's just the beginning. Doing the right thing ain't easy. And we need good guidance, good judgment, and determination to be able to make a difference. And again, these realities are shocking and inhumane. And the 11th commandment is that we must eliminate, we cannot commit isms. And unfortunately, they're everywhere, they're unconscious, they're conscious, and we must improve as we go forward. Next, please. So, what do we do? These huge problems. What can we do? My suggestion, my recommendation is, first of all, that we work to enhance our resilience. As it turns out, part of our common humanity includes certain characteristics of our brain, of our psyche, of our intellect, of our minds and our brain and our heart, which constitute a resource for resilience, which allows us to maintain some equanimity, some quality of life while we are working to eliminate these horrible realities that have just been described to you. So work to improve your resilience. And while you're working on your resilience, do what you can to do the right thing to move the agenda. And we know what the right thing is in most cases. It's not rocket science. It's just to be fair. It's to treat one another according to our common humanity, to our common realities, our common existence. And those are the things that we want to do when we think of ourselves as fellow humans, and remind ourselves that we want to treat each other as fellow humans, and not allow it to continue to be a reality that, in a sense, our healthcare program, in some countries, healthcare is a human right. In our country, I'm sorry to say, at least I believe, and I think I can justify the belief, that our healthcare system works according to the law of the jungle. Our healthcare system, in my respectful opinion, right now, very much works all too much to the law of the jungle. And if you're on that list of 13 or so people I mentioned to you, your healthcare may depend on your financial resource and your connections. And if that doesn't put you into an advantageous position, then you are subject to not succumbing. And in my mind, that's the law of the jungle. And so if you don't have enough financial resource, you don't have the connections, you're at risk to experience healthcare disparities. Next, please. Well, I believe this may be our final point. I hope this leaves, I believe, ample time for discussion. And I turn this over to my able moderator, my friend and colleague, whom I take credit for discovering very early when he was a younger man. And I thought he showed great leadership potential. I encouraged him to direct some of his talent and interests and intellects to the development of our medical school, our medical center. And he did that in a very admirable way. And I'm going to claim to be a little bit of a mentor for him. So it's a pleasure, Dr. Henderson. I hope our time is okay at this point.
Your timing is perfect. Thank you so much. That's very kind. Dr. White, that was fantastic. I do have some questions for you. For example, how can we better educate ourselves to healthcare disparities? You know, knowing that we have a wide variety of people in our audience, how can we better do that?
Well, of course, there's information everywhere. I mean, there's information overload. Not. I don't mean that critically, but I mean there's plenty of information. So I think that's one thing that it's important to do. And as I said, I think to pay some strategic and thoughtful attention to enhancing one's resilience, so that one can have a decent quality of life and be comfortable, and then address these terrible realities, these racial realities and these other realities that are not going to go away for a while, and need us to assiduously to work on those. So develop our resilience and then address these difficult challenges, and do that in a spirit. I was at a conference and sort of experienced a new kind of thought, but one of the participants was an enthusiastic young woman who was a physician. And she said, you know, as we work on all these problems, we can do it. And we want to strive to have equitable health care, but not just equitable care, but joyful care. We want to be joyful. We want to be happy. And the World Health Organization actually describes good health to include good emotional feelings. And we can easily call that joy. So my short answer is develop our resilience, address the disparities, and work hard. And they're not going to go away tomorrow for sure. And that's where our resilience comes in. But while we're working hard, we can make a difference. And there's no secrets either. I mean, it doesn't take a whole lot of skill to know what the right thing is to do to try to give people humane care. And I think that would be my broad kind of advice. Develop our resiliency and work like the Dickens, because it ain't going away, and it can be improved just by doing the right thing and treating one another according to our common humanity. And such things as empathy are so crucial and so helpful in interpersonal relations. And that's in everyone's sphere of influence, to treat our fellow humans, to treat others with respect. And if you do that alone, you will eliminate a lot of the unconscious bias that we all potentially can be involved with unconscious activity. But if you do that and try to treat everyone with respect, that will diminish a lot of the unconscious bias, unconscious healthcare bias and disparities.
Sure. That's great. I often get this question in my work in diversity, but I want to hear how you respond to this. Why is it so important to increase diversity of caregivers? Why is that such an important thing right now?
Well, right now it's because it's important because it's so needed. It's so prevalent. The thing that we're trying to change is so prevalent. So I think that's what we need to do. And I think that diversity, there are all kinds of studies that show that diversity in businesses do better, not just racial diversity, but ethnic and of course gender diversity. And there are many studies that show that diverse organizations do better. And other organizations have learned this. I mean, I think the military is one, I think. And a lot of places, it has been shown that having a diverse group of participants enhances the efficacy of an organization. Many businesses, many examples. And it's because people can learn to respect one another, can learn to work together and have synergistic activities in their work, and have ideas, bring a variety of different ideas and different solutions to a problem that may or may not occur with just a monolithic type of ethnic or cultural approach to the problem. So I think that clearly the interests that many organizations, as you well know, new jobs and new things created, new mandates that people have to try to enhance diversity is taking place, and I think is beginning to have, and certainly will have an improved effect on having these organizations function and coming closer to a realistic solution. And it's fun to encourage people, who maybe aren't so ready to believe some of these things, if they'll just take the IAT test, the Margarine Banaji. I think you can get it on IAT.com. I'll bet you can find it. I haven't looked quite that way for it, but I know it's out there. But Margarine Banaji developed this test, which allows you to know about unconscious bias that you may have, and you can take it in the privacy of your own computer, and you can learn about your biases and be more sensitive to trying to address them as you meet different patients.
That's really great. What are some of the ways that we can address unconscious bias for those who, there's parts of the population we are fully aware of what these issues are, but still there are parts of the population where it's kind of an unknown entity of what unconscious bias is. How can we better teach this to people and make them aware of their unconscious bias? You mentioned one test. Are there others?
Yeah, the IAT test. But I think, I don't know that I have secrets about this, but I think people should be taught, and it's a valid concept that people, it doesn't just help the biased person or the unconscious biases. It doesn't just help Asian Americans to learn that they can be the targets of bias and prejudice and unfair treatment, disparate medical care. But it helps the caregiver too. I mean, it's sort of a win-win situation. Some of that is innate. It isn't always the case, but there's when one expresses empathy and gets evidence of a human interaction, one reaches out to try to humanize a person of a different ethnic group, that is gratifying to the caregiver, to the physician as well. And actually, there are not a lot of studies, but I'm aware of one study that shows that by showing empathy, the patient is more satisfied and gets a better outcome and is less likely to be involved in lawsuits. And it also makes the caregiver feel better. And the physicians who are engaged in empathetic care are less likely to experience burnout. And so it's a win-win situation to try to reach out to your fellow human to do the right thing, to treat them with respect and humanize them, treat them as human beings.
One question from the audience asked, how do we get our colleagues in the healthcare field to open up regarding their isms, to be more receptive of their blind spots?
Well, that's a good and challenging question, I think, and it's important because I mean, it's hard to make, for example, a financial incentive. If you think about healthcare, I was thinking about this in very broad brushstrokes. I believe it should be a human right. I think healthcare should be a human right, and we're a long way from that. But as we look at ways to connect it with incentives to get people to make the extra effort to try to be more certain that they give disparate care, I think it's to try to impress upon them our common humanity. The fact that they even are in medicine in the first place means that they do have some inclinations and that they can do things without harming themselves to eliminate their conscious and unconscious biases if they think they may have them, or may have some, such as getting to know a person of a particular ethnic group, if that's a problem, getting to try to work with someone whom you respect but is in a different group, but it can help you, I think, to diminish some biases that you may have. But I don't know if there's any direct formula to do this, but I think that if one can be motivated to recognize that it's better for the whole society, again, are we a humane society, or are we a society that is going to live according to the laws of the jungle? And we're fighting for that. And I'm a terrible historian, but my historical concept is that the results of history is the result of an eternal battle between the good guys and girls battling against the bad guys and girls. And I think you can summarize history on that basis, that you just have to keep fighting for what seems to be right, what you believe is right. And it's not going to happen by any kind of magic evolution, but it's going to happen by addressing it and doing what we can, each in our own sphere of influence. I guess that's another point I'd try to make. All of us, whether we're the CEO of the hospital or CEO of the corporation, a general in the Air Force, or a third-year resident, we have a sphere of influence. And within that sphere of influence, we can do the right thing. And generally, we know what the right thing is. It's not rocket science. And if we will try to every day do something that is in our sphere of influence, something that we could do that made a difference, do that. And that adds up. And that, as I said, that makes us feel better, but it also is a wave of hope that can push back against the huge waves of dissatisfaction and waves of undesirable behavior and move us in a more become a more humane society. And I don't think we should ever underestimate that. I mean, it really adds up, and it's something we have the freedom and the opportunity and ability to do, just on a day-to-day basis, treat everybody with respect.
As we do that and also participate in work involving diversity, inclusion, and equity issues, how can we measure success? That's something that's important.
Yeah, yeah. And well, I think that we have the one thing that we all already have is the tradition in medicine of doing clinical follow-ups in developing certain variables, whether it's treatment or whatever those variables are, exercising those variables and observing changes in the places that you want to make those variables. So I think the same way we've done, how well does a given operation work? And if you do it a little different this way or different that way, how much better does it work? And follow that, I think is very valuable, and publish that, and hope that other people who want to do the right thing and make progress will follow those guidelines. I wish I could give you some histories of that happening, but I'll bet they're out there. I mean, I think if we carefully travel, I do know that Dr. Manaji is wanting to do, she has some ideas about how to teach culturally competent care, how to get people to give equitable care to those groups of 13, the lady sitting on the operating table, the slightly overweight African-American female, how we can get people to make an effort to make sure they give her equitable care.
One additional question is also from the audience. How do we incorporate this type of education in diversity and equity issues in medical education or postgraduate medical education for residents or fellows, and throughout the continuum, the spectrum? Mm-hmm. How do we best do that?
Yeah, well, this isn't part of the question, but just briefly, I assume that more schools are going to offer more courses at the college level, and that can be expected to feed into the kind of outcomes that we need. That's one thing. But medical schools, I mean, there are guidances from the AAMC guidelines and CME guidelines that I think are very useful to engage people in studying and trying to adjust their practices and activities in a way to diminish these disparities. And I'll bet more and more of these will be operative in the future, and people will probably attempt to find more and more ways to incentivize caregivers, nurses and doctors to give equitable care. And we're trying to do that right now as you and I speak in this meeting. And these are the things that I do believe will help. And as I said, I do believe if people will just the next day when they go to work, just say, hey, I heard this and I want to try to do it, and just reach out and start by humanizing the patient. Think, well, I'm trying to treat this patient as the double F criteria somebody taught me, friend or family. And I'm going to try to humanize this patient, even if we just talk about the weather. What do you think about the weather today? It's a human issue, but it identifies the patient and the caregiver both as human beings. So I think work our sphere of influence, and more institutions will develop as people are already hiring more and more people to work on diversity, equity, and inclusion. And I think that's the progress, and that's where it needs to be. There are no secrets. As I said, it's not rocket science. We know what the right thing is. Right. We just need to do it.
Dr. What gives you hope in all of this?
Our common humanity. I think that we have a reserve of righteousness, if you will, in our as human beings. And I think as long as people want to address this and want to point to it, I think we can make progress. And the fact that other cultures have done a little better than we have, and maybe that will offer us some guidance and some incentive. But that's the main thing. That's where it is. I mean, it's in the negative, the bad part that's in our common humanity. There's also a lot of good, and I believe more good there that will help us to be righteous, because it isn't hard to understand healthcare, and even people who are not in the unfortunate 13 know what it's like to suffer from ill health, and so it's not as though you're trying to sell something that isn't real, that people don't know what you're talking about.
I'm going to pivot just a bit and ask a little bit more about you and your experiences at Brown and right after Brown. While at Brown, who were some of the people that influenced you in your career trajectory?
I was fortunate at Brown at having a number of good professors, good teachers, but I think Dr. Anthony Davids, professor of psychology, was someone who reached out to me and agreed to be a mentor for me, and was most helpful in having me go forward in my education at Brown. And he basically invited me to, I was coming out of class one day, a psychology course, and he said, Gus White, yeah, he said, make an appointment in my office. I want to talk to you, see if you'd like to do a thesis. And I said, yes, sir, thank you. So I did, and I ended up doing research with him, but he took an interest in me beyond. I mean, we worked together enough to have a paper published in the Journal of Psychology, my first publication. But he also wrote recommendations for me to get into medical school. And we both had in common, he was a wrestler at Harvard, and I was a wrestler for a while, so we had that in common. One thing I like, when people ask me about my mentor, though, one thing I tell people is get to know your mentor a little bit. Mentor gets to know you and wants to help you, but also get to know your mentor. And I missed one thing about him that I really was sorry about it, but he was a fighter pilot. And I never knew that. And I felt bad that I didn't, because obviously I would have had additional respect and appreciation for him if I'd known that. And so when I'm talking sometimes with my mentees, talking about mentoring, I encourage people to get to know your mentor.
That's great. Can you share with us some examples of times in which you encountered patients who had biases towards you or against you? Can you share some of those?
How about one?
Okay.
I was rotating as, I guess, a junior medical student at Stanford. Stanford, interesting, combined its medical and surgical clerkship into one clerkship. And anyway, we had this patient, sort of a middle-aged Caucasian man who was on my service. He was my patient, and he was all up to date. Everything was taken care of medically. And I thought, well, I'll just go by and make kind of social rounds, and just to say hi to some of my patients. So I just went by purely to say hi. He had a terminal cancer. And I thought I'd just kind of cheer him up. As I said, a middle-aged Caucasian man. So I just said, Mr. Smith, I don't remember his name right now, but how are you? And we just chatted, and turned out he was from Washington, D.C. And I thought, whoa, and I had just had a chance to visit Washington for some reason, I don't know, but I said, gee, yeah, we both so many things to do, so much sightseeing, so many things to see and do in Washington. And he and I were just having this wonderful conversation, and said, and having great, I enjoyed going to the museums and going to things, various things. And he said, yeah, he said, that's all great. He said, but there's one problem. There's one problem. I said, what is that, sir? He said, too many niggers, too many niggers. And I just took a big swallow. Well, good afternoon, sir. We'll see you. We'll see you later. See you tomorrow. And left. But it was just such a distinct contrast, that it just kind of slapped me in the face. But it didn't. It was as humorous, I guess, as it was sad. But I didn't have, a lot of any patients refusing to have me treat them or anything like that. The momentum was there, and everybody at Stanford momentum was so good that people didn't want to push back against that, I guess.
Great. One of the additional questions: what are some of the strategies caregivers can use when speaking with their patients?
Did I ask you to ask me that question?
That was one of them.
Well, good morning, my fellow human.
Okay.
Goodbye, my fellow human. This is something that I learned not to use with patients, but to use in general. And as you heard, I introduced my topic by saying, good evening, my fellow humans. And that's the way I've introduced all of my topics since I first heard it from Dr. Montague Cobb. Mm-hmm. Yeah. Dr. Cobb, obviously, as you're nodding, is a distinguished African-American scholar, educator, civil rights leader, who was a professor of anatomy and at Howard University Medical School. And he was also editor of the Journal of the National Medical Association for many years, also chairman of the board of the NAACP at one time. Phenomenal career of leadership and a phenomenal teacher. And when I invited him to come and lecture when I was at Yale, and I invited him to come and lecture when I was at Harvard, somehow I had a chance to invite speakers. That was part of my participation in the department. And each time he introduced his lecture by saying, good morning, my fellow humans, or good day, my fellow humans. And it's a wonderful reminder, I believe. And so that is something that I have appreciated very much, and it comes from Dr. Cobb. And it's another iteration of saying treat all people with respect, and try to humanize your patient or the person that you're working with or dealing with. And so that's so you can say good morning, my fellow human, and how are you? Or just smile, or just have eye contact, or as I said, talk about the weather, or talk about the grandchildren, or whatever. But reach out to the person as a human being. And it only takes a millisecond. It's good. The more you have more time, and you can do more extensive. But just to connect the dots, I think helps a lot.
I noticed that in your career was built as an orthopedic surgeon. You're an orthopedic surgeon, and not necessarily a public health primary care physician. I think many people now think that in order to do DE&I work, you probably should consider being a primary care doc, or a public health doc, or a public health caregiver. Any comments regarding that?
Well, I think either way it is fine. I think that clearly, in terms of some of the organizational and research activities and innovations, and I think a public health perspective is very helpful. But it's also important and helpful to have people in various specialties who can still apply some of these organizational attributes that one would learn more of in public health. But still, I think one can apply those things as well, or can apply other things, and can see things that from a different perspective. So I think it depends more on the person's interest and motivation rather than a person's degree. I mean, you could raise the question, well, an MBA, some people who want to have leadership and do leadership roles in medicine will do an MBA, which reminds me, by the way, of a wonderful program that I've sort of stumbled across at Duke Medical School as a result of my having a friendship and having as my commanding officer in Vietnam, an orthopedic surgeon named John Fagan, who was one of the first, he's the first West Point graduate to go right through medical school and have it not be, have it coordinated with his military education and his military career. And he was my commanding officer in Vietnam. But he recognized that, great doctors are not necessarily great leaders. And great doctors oftentimes get involved in places where they're in leadership position, but they're not, they don't have the leadership skills and training. So he started a leadership program at Duke Medical School, which has continued and is very impressive and something I have great appreciation for and great respect for. And it can readily be applied to a person of any specialty, and something that does pay attention, and he does in his leadership training program, include issues of diversity and inclusion and healthcare disparities. That's not the entire purpose. The entire purpose is overall leadership skills. And he has a lot of support from his own military training, his own West Point training, but his connections with West Point generals and so forth who've helped him with this course, which is, I think, is quite a contribution and something that can be readily applied to some of the concerns and some of the desires of anyone to have leadership role in medicine to address healthcare disparities and improve healthcare issues. So anyone interested, take a peek at the Fagan Leadership Program at Duke Medical School.
Dr. White, we only have about 5 to 6 minutes left. I really would enjoy if you could tell us just a little bit about the 2 books that you have written. The first one is regarding seeing patients, and the second one, I believe, Overcoming. Can you say a little bit about those 2 books?
Sure. Well, thank you for a chance to talk about this. I didn't know you were going to ask me that question. Does this show up on the radio screen here, radar screen? This is one. This is, wait, that's the wrong one. This is a good book, though, by the way, Resilience by Stephen Southwick. And we talked about the desire for resilience. So keep that in mind. Resilience, it's a really good book for resilience enhancement. And the other one that I wanted to show you is called Overcoming. And this is stories of resilience where individuals who have overcome tremendous tragedies, all kinds of different tragedies, and how they overcame those tragedies and how their common humanity was a helpful resource to them in overcoming these tragedies. And it includes people doing it from a variety of different perspectives. And I think it will be helpful to those who want to enhance their resilience and can look at a variety of ways that other individuals did improve their resilience, and they worked with common resources that we all have as fellow human beings. So it's called Overcoming: Lessons in Triumphing Over Adversity and the Power of Our Common Humanity. So that is the more recent book, and I think it would be useful in resilience enhancement. And the other one is called Seeing Patients. And this one I think I can show you as well. This one, yeah, this one tells about, it's sort of my journey in terms of trying to get to be a doctor and trying to get to be a good doctor and trying to take care of people and try to be a good fellow human. And so that's what that one is about, called Seeing Patients. And I had some very good help with co-authors on both of those books, actually. So thank you for asking that. I appreciate that.
Sure. And I believe Ruth Simmons wrote the preface in.
Yes, that's right. That's right. Maybe I can read it. I missed the graduation speech, though. I was so sorry. She gave the graduation commencement address here at Harvard the other day, and I missed it. But let's see, where is she? Okay, this is from Ruth Simmons, fellow Brown people, friends, fellow Browns. Ruth Simmons, this is about our book, Overcoming, and I'm proud and happy that I can read this for you. It says, resilience is a popular term today, and it has become even more important as the world crises deepen with no end in sight. Reading about these heroic struggles, our backs straighten, our confidence in the future is reborn, and our self-pity melts away. We can all find buoyed by these profiles in determination. Ruth Simmons, President, Prairie View A&M College now after she's left Brown. And I'm so happy to share that here at this Brown meeting, though, from Ruth Simmons. Thank you for that opportunity.
Right. Dr. Gus White, thank you so much for this evening with this information. It's been tremendous. I really appreciate you, and I appreciate all of the people that have attended this conference this afternoon. Please enjoy the rest of your night, and I will keep in touch.
Thank you. Thank you, my brother. I appreciate it very much. I enjoyed it very much.
Great. Thank you.
Take care.